All right, and the webinar is live, and wow, people are just piling on in. Hi, everyone. Thank you for joining. My name is Omar MKT. I'm the Director of Growth here at Potrero Medical, and what can I say? We have yet another amazing webinar, this time, as always, with a very special person, a very important person, and we're very lucky that she took some time to join us, Dr. Rosemary Lee. Rosie, are you there?
Yes, I'm here. Thank you.
Perfect. I don't know why I asked. I mean, I can see you, so obviously you are. And of course, my co-host and dear colleague, Brian Bechtel, our Director of Clinical Marketing and Clinical Engineering, who's also got deep clinical expertise in intra-abdominal hypertension and pressure. So Brian, thank you for joining us. How's it going? And you're up in New York, right?
A little bit of rain. It's pretty nice. Fall is a good time to be here.
Got it. It's boiling hot right now in California. We're in fall and it's still hot here. So Rosie, where are you calling in from?
Homestead. We're just south of Miami, just north of the Keys, and luckily there's nothing swirling out near us at the moment.
Perfect. All right, well, I see all right, the registrants are just like, it is skyrocketing. I can't tell you how much fun it is to see that number. We have a wonderful group of people joining us from all over the world and all over the country, people from Hopkins, UCSF, Cedars, other places in Europe. I think I saw somebody even in Australia, which is pretty late over there, but we welcome it. So we'll give a minute or two for people to come in. We know that people are coming in off of rotation, and we'll get started shortly. So perfect. So a couple of housekeeping items I want to address with everyone. So first, this is, as you can see, it's a Zoom webinar. One concern is that a lot of people want to share this with your teams. The good news I have for you is you can. So if you have to hop off for any reason, or for some reason you want some of your teammates, other nurses or clinicians to watch this, this will be recorded. So if you registered for this webinar, you will receive the recording as well. And then once the webinar is done, we will put this on our website so you can forward this on to your colleagues. The other good news I have, and again, it's thanks to our wonderful speaker, Rosie has provided the PowerPoint slides, which will also be uploaded on our website and sent to all the registrants. So the good news about that is that there's a lot of extra goodies in those slide decks, so you'll be able to have access to those. So Rosie, thank you very much for doing that. Now, the format of today's webinar is going to be very simple. We're going to do a quick introduction. Brian was going to take over as moderator. And after Rosie goes through her slide deck, about 20 or 30 minutes, give or take, we'll get right into the live Q&A session. So during the Q&A, here's the key. Don't wait till the Q&A to send the questions. If you see a slide and you have a question, send it to me right away, because we end up with a long list of questions. Sometimes we can't answer all of them. So send it to me right away in your Q&A box. If you look at the bottom, there's a Q&A box right down there. So you can send that question to Brian, and I will ask that question during the Q&A session. Any questions we're not able to answer during the live Q&A, because again, as much as we appreciate her time, we can't keep her on here forever. We'll be following up with each individual person to answer those questions afterwards. So I guess without further ado, Brian, let me hand it over to you. Go ahead and introduce yourself, introduce Rosie, and let's get the show started.
All right, thanks, Omar. Welcome, everybody. I have the honor of introducing my dear friend, Rosemary Lee. I call her Rosie, and after she got her DNP, I now call her Dr. Rosie. Rosie has been a longtime colleague, friend, and advisor of mine for probably going on almost 20 years now. And the first time I met Rosie, I was working at Jackson Memorial Hospital in Miami talking about intra-abdominal pressure devices when they were new and the cutting edge thing, and they were just kind of coming into the marketplace, and we were trying to figure out what to do. And one of the doctors in the trauma team leaned over to me and he said, "You need to go find Rosemary Lee at Baptist." So he told me where to find her. And when I got to Kendall Baptist, she came bursting out of the ICU doors, and it has been a wonderful friendship ever since then. So you are in for a great treat listening to Rosie's presentation. To just give you a sense of Rosie's background and who she's dealing with, who you're dealing with here. She's been a nurse since 1973. So she has seen everything and a lot of things in critical care and all those changes. She's been a clinical nurse specialist since 1991. She's currently working in an EICU capacity with Baptist Healthcare, offering her expertise and guidance with remote critical care support for her team. So Rosie, thanks for all you guys have been doing down there and all the nurses everywhere for what you've been doing in the year of 2020. Rosie's also been a nursing professor, teaching probably literally thousands of nurses over her career. She did also do her doctorate capstone project on intra-abdominal pressure and intra-abdominal hypertension that was also published. Congrats, when she was working on her DNP. She is a member of the American Association of Critical Care Nurses. She's also on the National Committee and co-contributor. So she's rewriting a lot of the critical care guidelines that nurses depend on in the AAC and procedure manual, including the IEP section. She is also has the privilege of being the first ever nurse ever elected to the executive board for the World Society of Abdominal Compartment Syndrome, which became the World Society of Compartment Syndrome. So congrats on that, Rosie. And it's nice to see that there's a nursing voice in that group too. And she's also a member of the Society of Critical Care Medicine and the American Nurses Association. And one thing I'd like to share about Rosie, just to embarrass her a little bit, but also of why I really value her friendship so much, is in April, living here where I do in New York City, I got a text one night and it said, "Are you okay? And do you need anything?" And that's the kind of person that Rosie is. So Rosie, and to all the nurses that were dialed in, thank you for who you are and what you have done this year. And we look forward to hearing what you have to present. I'll turn it over to you.
Ryan, thank you so much for that kind introduction. You're making me blush like you said you would. Okay, now I'm going to share my screen, I hope. There we go. Okay, so title of this is the Intra-Abdominal Hypertension ICU Nurse-Driven Guidelines. And in the February issue of Critical Care Nurse, we did have these guidelines published. So, and most of the pictures that you see here are nurses that I've worked with in the past. So they will remain nameless at the moment. So here we go. All right. All right, so my disclosures, as you can see, I am a consultant speaker for Potrero. And also, oddly enough, I'm a special employee of the Food and Drug Administration. Okay, so the objectives, by the conclusion of this presentation, you guys will be able to state the physiologic effects of intra-abdominal hypertension and describe nursing interventions that can be initiated to reduce the intra-abdominal pressure. Now, one thing I want to say is I have a lot of slides, and I'm going to breeze through many of them because they're just kind of like laundry list of risks or signs and symptoms, etc. But since you will have the slide deck available to you, you'll be able to refer back to them. Okay, so for those of you who know AACN, they have the synergy model for patient care. And one thing that they say that our role is that our role as acute critical care nurses is to provide safe passages to patients and their families. So, I like to think that, by monitoring and intervening on intra-abdominal hypertension, that we as nurses can make a difference and provide safe passage. So, as acute and critical care nurses, we monitor and screen our patients for potential complications, sepsis, pressure injuries, falls, CAUTIs, and catheter line-associated bloodstream collapses. So if you had the knowledge, tool, and expertise to identify and intervene on a seriously complication of the critically ill, wouldn't you want to act upon it? I'm sure your answer is yes. So this is just a little summary about the World Society of the Abdominal Compartment Syndrome. They identified the fact that when people were beginning, the medical community was beginning to understand the seriousness of intra-abdominal hypertension, there was a lot of research going on, but some people were measuring in centimeters, some people were measuring it in millimeters of mercury. There wasn't a standard as to what's too high, what's acceptable. So this group of physicians got together and developed definitions and recommendations and guidelines. So they were founded in 2004. And its members do include, all various of the healthcare team. And they did initially put out their guidelines in 2006 and 2007. They revised them in 2013, and the plan is to update them again in 2021. They meet every 2 years on the odd years to have their World Congress. I'm not sure what we're going to be doing in 2021 just yet, though. So the World Society of the Abdominal Compartment Syndrome has changed their name to the, as Brian had said, to the Abdominal Compartment Society. So let's just make sure we're all on the same page and make sure we all know what intra-abdominal pressure is. It's the steady state pressure concealed within the abdominal cavity. Normal in adults is 0 to 5. A typical ICU patient is about 5 to 7 millimeters of mercury. Now, intra-abdominal hypertension is defined by a sustained or repeated pathological elevation in IAP that is greater than or equal to 12. So again, just like one blood pressure doesn't give you a diagnosis of hypertension, you need to have a repeated elevation. The Abdominal Compartment Society has also developed a grading system. Grade 1 kind of being mild up to grade 4 being a surgical emergency. In grade 1, decompression is not indicated. You're just going to keep an eye on them. Grade 2, treatments based on the patient's clinical symptoms, their conditions. Again, you're going to keep monitoring. Grade 3, abdominal decompression is indicated even in the absence of overt signs and symptoms. And then grade 4 is considered a surgical emergency. So there's also the abdominal perfusion pressure. Many of you guys, I'm sure, are familiar with cerebral perfusion pressure. Well, it's calculated essentially the same way. You take the mean arterial pressure and minus the intra-abdominal pressure. And the target that you want to shoot for is an abdominal perfusion pressure of at least 60 millimeters of mercury. And this has been shown to correlate with improved outcomes for patients. So abdominal compartment syndrome is defined as a sustained intra-abdominal pressure of greater than 20 millimeters of mercury that is associated with new organ dysfunction or failure. We're all familiar with that with the sepsis guidelines. And with or without an abdominal perfusion pressure of less than 60. So what are the causes of intra-abdominal hypertension? Well, the Abdominal Compartment Society has divided these up into primary, secondary, and recurrent. So primary abdominal compartment syndrome is usually an underlying surgical cause. So it can be corrected, repaired with either surgery or interventional radiology. Just some examples. Again, this is a laundry list, so I'm not going to go through all of them. But in this slide, you can see this guy has the type of retention sutures we really don't want to see anymore. And then secondary abdominal compartment syndrome is a medical cause. It refers to conditions that do not require surgery or early interventional radiological intervention. And these are the big guys in our ICU. So this is more medical causes, and this is really where we need to pursue our concentration when it comes to managing intra-abdominal hypertension. So I am going to go over this list. Intra-abdominal infections, massive fluid resuscitation, such as we do for the sepsis patients, pancreatitis, ileus, sepsis, major burns, and then there's some chronic causes. So these are medical causes of intra-abdominal hypertension. And then recurrent is just what it says it is. It's, you treated it once and it came back, whether it's medical or surgical. So this slide I stole from one of the Abdominal Compartment Society guys, but there's overwhelming evidence that supports that more than 50%, and some research studies even say 80%, more than 50% of ICU patients have some degree of intra-abdominal hypertension. Surgical patients get it more frequently, but medical patients get it worse and die more often. That's why it's so important to kind of zero in on these medical patients. It has been identified as an independent risk factor for death. So it can cause the death of our critically ill patient. It is a cause of multi-system organ failure. And it's been shown that abdominal palpation is not sensitive or specific enough to identify intra-abdominal hypertension. And below, there's a list of research articles that support these statements. So abdominal hypertension and abdominal compartment syndrome are common entities in the critical care environment. They increase morbidity, mortality, and ICU length of stay. Clinical signs of intra-abdominal hypertension are unreliable and only show up later on in the clinical course. So early monitoring and trending, and as critical care nurses, we know this. When we're doing hourly urine outputs and we gradually see our urine output, going down and less, or when we're monitoring heart rates or blood pressures. So we know that monitoring and trending is very important. So it's the same with intra-abdominal hypertension. So whose intra-abdominal pressure should be measured? Well, what the Abdominal Compartment Society's recommendations are that intra-abdominal pressure monitoring should be considered if the patient has any one risk factor for intra-abdominal hypertension. And there are many risk factors for intra-abdominal hypertension. They have them listed in categories: diminished abdominal wall compliance, increased intraluminal contents, increased intra-abdominal contents, capillary leak, fluid resuscitation, and other miscellaneous. And when you see these risk factors, I'm not going to read all of them out again because they're like laundry lists, and you'll have the slides, but you'll see just about every patient in the unit has at least one risk factor. Okay, so this is your diminished abdominal wall compliance, increased intraluminal contents. And I know many of you guys probably ate lunch, but I didn't think that these pictures would be bothersome to you. Increased intra-abdominal contents, capillary leak, fluid resuscitation, and here you can see our sepsis patients come into play. And for the hypothermia, just to back up, for hypothermia, that includes targeted temperature management also. There are multiple risk factors. So then what are the physiologic effects of intra-abdominal hypertension? Well, it does affect every system in the body, from the brain down to the feet. Okay, so I could take hours going over all the negative effects of intra-abdominal hypertension, but this picture summarizes it greatly. Neuro-wise, it does increase intracranial pressure. It does decrease cerebral perfusion pressure. It does increase pressures within the thoracic cage, so it decreases cardiac output, decreases pulmonary compliance, and so on. And I'm going to talk a little bit later. Let's see if I can get a little pointer here. Yes. Okay, so I'm going to talk a little bit later too about the cardiovascular effects when I get into the nursing management. But just to note that, notice how it says that when you have intra-abdominal hypertension, it increases the pulmonary artery pressure and the CVP pressure. But realize that those are false elevations, or not quite accurate elevations, because 50% of the pressure in the belly gets directed up to the thoracic cage. So when you kind of put the squeeze on the thoracic cage, it falsely elevates the wedge and the CVP pressure, so that you may think that it's elevated. And I can remember I've had physicians see a high wedge pressure or a high CVP and order diuretics, when actually what the patient needed was more fluids. So again, we'll talk about what parameters can help us the most when it comes to monitoring the hemodynamics. So why should we measure it? Couldn't we just do a hands-on assessment? And as I mentioned earlier, there are several studies that indicate that the hands-on assessment for assessing for intra-abdominal hypertension is not accurate. It's not sensitive enough. It doesn't have positive predictive value, and it's not very accurate. So again, just like you're not gonna, I know a lot of times we put our hands on a patient's forehead to see if they have a fever, but that's really not the most accurate. And you need to actually measure it. Just like you can't tell by looking at a patient what their blood pressure is. You have to measure it to see what it is. So how often should intra-abdominal pressure be measured? Well, our nursing group who developed these guidelines, we discussed this a lot. And we said, well, you know, you have to see if you have a trend, because we said that just one reading of intra-abdominal hypertension does not give you intra-abdominal hypertension. You need several readings. So initially every hour until you get a trend. And then after that, every 4 hours. But let's say you have a high intra-abdominal pressure, like let's say intra-abdominal pressure of 18, and you're doing various interventions to lower that intra-abdominal pressure. Well, then you want to measure it more frequently. But then, you know, right now, all we have are intermittent ways of measuring intra-abdominal hypertension. And I kept thinking, you know, wouldn't it be great if we could have a continuous measurement? It's like if we had an A line, or, you know, how you have continuous measurements with an A line. And what's interesting is that there is a new tool, the APRN, and this device can monitor intra-abdominal pressure continuously or intermittently. And it also, on top of that, measures continuous urine output and bladder temperature. So now let's talk about collaborative management. So primary conditions usually require surgical intervention, and secondary conditions require a stepwise approach based on the causative factors. Now, as I said earlier, it's, you know, surgical patients get it more often, but medical patients get it worse and die from it more often. And that's because it's not always looked at as a medical problem. So the society developed a medical management guideline to assist non-surgeons in managing intra-abdominal hypertension. And this is the medical management algorithm. It is a free download from their website. And what I'm going to point out are just the headings. So what they did is, this is evacuate intraluminal contents. And then they have a stepwise approach of medical management guidelines of how to bring it down. Evacuate intra-abdominal space occupying lesions, and they have, you know, interventions, improved abdominal wall compliance, interventions, optimized fluid administration, and then optimized systemic regional perfusion. So these are all evidence-based that were developed by the Abdominal Compartment Society. Let me just back up here. And so when we got together to form our nursing management guidelines, we based it on the medical management guidelines. But then more or less what the Abdominal Compartment Society says is that if all else fails, you know, and the pressure is greater than 25, the abdominal perfusion pressure is less than 50, they need to go to surgery, regardless if it's a medical or surgical condition. And just to point out too, how open it is to work with the group at the Abdominal Compartment Society. When they developed these medical management guidelines, you know, I said to them, I said, you know, you have these great medical management guidelines, but it's us nurses who are really doing the measurement. We really need some nursing management guidelines. They said, okay, go ahead, do it. And what they did is they gave recommendations of their nurses who should be on the guideline committee also. So speaking of that, these are the nurses that were on the committee. Most of us are from the US, but we had Leanne Hunt from Sydney, Australia. We had Kathleen Bumbecki from Belgium. And Dr. Educate, we had her because she was our only pediatric specialist. So she agreed to do the pediatric portion of the guidelines. But I'm only going over the adult guidelines. And then our executive committee were Dr. Dewell, he at the time was the president of the Abdominal Compartment Society, Nikki Delat from Belgium, and Dr. Kirkpatrick from Alberta, Canada. So as I mentioned, the medical management guidelines are evidence-based, and the nursing management guidelines are derived from these medical management guidelines. So we recommend implementing these guidelines in an interdisciplinary manner. And the hospital I was working at the time, I got together with the medical director and the nursing staff, and we developed like a nurse room protocol to manage intra-abdominal hypertension. The full guidelines are there. So if you guys, if any of you guys are AACN members, you probably have the journal already, or you can go to the website and download it for free. So I'm going to go over just some of the excerpts. I'm not going to go over every single guideline because you guys will be falling asleep in your soup. So I am going to go over the ones that I think are most concerning. Okay, so again, for the heading, evacuate interluminal contents. Well, what they say is, put in an NG tube, give an enema. Okay, so what we say is that, okay, put in an NG tube, but maintain patency of the tube, ensure it's properly positioned, make sure the appropriate suction is there for the NG tube. And again, some of these seem very simple, but I'm still surprised at how many nurses don't do these things. Okay, so in this x-ray, it's just showing you an NG tube that is coiled in the stomach. So the tip is up here in the fundus when really you want it further down. So although, you may have auscultated, you may have suctioned out nasogastric contents, really it's recommended to do an x-ray to confirm the placement of the tube. So again, this tube really wouldn't help much with draining the abdominal cavity, the stomach. And then in this one, the article that came with this x-ray stated that, when the nurses put the nasogastric tube in, that they did auscultate and thought that they were in the right spot, but actually the tip of the tube is right in the esophagus. So again, not that we interpret the x-rays, but we can read the findings in the x-rays. And the x-rays, we usually say NG tube in the esophagus or at the GE junction needs to be put down further. So don't pass those up. You need to look at those x-rays. Okay, so now what is this? What is this? Let me tell you this story. This is the story of a woman that was in her mid-30s. She was pregnant with her third child. And she was one of our migrant workers and didn't speak any English. She was from Nicaragua and didn't speak and spoke a dialect that was not readily available. But what happened was she prematurely went to labor at home, delivered the baby. She was brought into the hospital by fire rescue, and she was put up on our postpartum floor. That night, she developed a board-like abdomen and a high fever. And so they called the emergency response team and surgery was notified and she was immediately taken to surgery. It turns out she had a very diffuse peritonitis. So the surgeon decided to, oh, by the way, the baby's fine. Baby did well. I know everyone wants to know that part. So they decided to leave her abdomen open and they had a wound vac type dressing on her that needed to be changed every 48 to 72 hours. Well, she had been in our ICU for maybe about a week, and I noticed that her interval pressure through the night had been increasing. She had been running like 10, 12, 14, but it started getting higher and higher, approaching the 20 mark. And I was kind of concerned about this. So I spoke to the surgeon and he said, well, we're going to change the dressing today anyway. Why don't you come to surgery and we'll see what's going on. So I went to surgery with them. They took off the vacuum packed dressing and lo and behold, this big thing pops out. It wasn't another baby. She did not have twins. So let me just orient you to what's going on. Her head is up on this end. Her feet are here. This is the omentum. This is just the suction. What this is her stomach. But she had an NG tube in. So why is her stomach big like this? Well, the anesthesiologist pulled out the NG tube and it was totally occluded and caked. It looks like no one had irrigated it for days. I was very embarrassed. He put in a new NG tube and she deflated like a balloon. Okay, so the importance of maintaining patency. And when I speak to some nurses about this, they feel that you need a physician's order to irrigate a nasogastric tube. The only time you need a physician's order is if they've had esophageal or gastric surgery. If you read the AACN procedure manual, it tells you when it comes to nasogastric tube suctioning that it's nursing care to irrigate it to maintain patency. So again, realize that you do not need a physician's order unless they've had recent surgery on the esophagus or stomach. Okay, so that was a lesson learned for all of us. All right, so now the one. Again, what the Abdominal Compartment Society says is give enemas. Well, we know that we want to monitor for bowel movements and when was the last one, and are they getting what they need so that they can have an adequate bowel movement? So are they getting enough fluid intake? Are they on stool softeners? Do they need a APRN laxative ordered? And then last of all, if you have to give an enema, give an enema. Okay, so this is an actual patient that we had. 49-year-old female. She was admitted with complaints of shortness of breath and palpitations. She past medical history, morbid obesity, hypertension, AFib, COPD, and HIV. In the ED, she was in respiratory failure, so they intubated her. They put her on a diltiazem drip, and she was hypotensive, requiring fluids and vasopressors. So she was admitted to the ICU. She was screened for IH risk, and her risk factors present were respiratory failure, morbid obesity, hypotension, and greater than 5 liters of IV fluid within 24 hours. So her IAP started rising, and they gradually rose to 22 over 4 days. KUB didn't show anything like a bowel obstruction or an ileus, but the nurses identified that she's had no bowel movement since admission. So laxatives and stool softeners were given. And of course, at 7 p.m. change of shift, she had a huge code brown. So we all got involved. And then her IAPs dropped, now averaging 12 to 15. The next thing is evacuate intraluminal contents. So, we hate to have to stop the enteral nutrition in our patients. So you really don't want to do that if you don't have to. But if you feel that the patient is not absorbing, you may want to speak to the physician to order a gastrocolopronetic agents. And several of them are listed there that can be utilized. You also want to discuss with the dietitian about minimizing or discontinuing enteral nutrition, but hopefully you don't have to. There are other protocols that you can use to help minimize how enteral nutrition is given. And then improve abdominal wall compliance. So you want to remove any restrictive clothing or binders or dressings. You want to titrate sedation and anesthesia to promote abdominal wall relaxation. You want to discuss with your provider if they're on a vent, can we initiate neuromuscular blockade? And I've seen that multiple times on patients who are on vents, and we cannot get the intra-abdominal pressure down by any means. And we implement neuromuscular blocking agents, and the pressure comes down. And then you want to assess burn patients that have abdominal and flank eschar for any tightness to prepare for eschorotomy if needed. So this is a patient with a binder, and I just saying unbind me. And I have to admit, I tended to be a little devious. We had a surgeon that loved to put abdominal binders on all his abdominal surgery patients. And if we were measuring IAP, obviously their IAP would be elevated. So it just kind of loosened that Velcro so it wasn't on so tight, and then the IAP would gently come down. And no one dehissed, they were fine. And then this is a burn patient, and you can see that he has gross abdominal distension. And I used to work in a pediatric burn unit back many, many years ago. And I can remember having this done on several children that I worked with, that their abdomens get so distended that, they can't breathe effectively, they can't absorb nutrition. So eschorotomies need to be done. So then again, positioning is a big thing with intra-abdominal hypertension. You want to improve abdominal wall compliance. That's the heading. And what the Abdominal Compartment Society says is keep the head of bed less than 20 degrees. But we know that for some patients that's not the most effective position. So this is just a little summary table from one of the Abdominal Compartment Society articles, and they did a study on how do different body positions affect intra-abdominal pressure. And the main position is the supine, the head of bed can raise it up 3 points, 45 degrees, 6 points, head up and feet up, 2 points, feet up and supine, 1 point, Trendelenburg, oddly enough, -4, and then reverse Trendelenburg. Originally, they thought reverse Trendelenburg would be a great position to put these patients in because it would take weight off the diaphragm. However, it actually adds points. And then the prone position also. But we all know that in this time of COVID, that the prone position is life-saving for many of our patients. So if the prone position is required, ensure that the pelvis and rib cage are supported so the abdomen is not compressed. So you want the abdomen to be able to hang free. And we know many of our patients have a big pannus. And so there are various different ways you can review in the literature about how can we, promote the abdomen of hanging free. Now, outcome data as to the prone position in patients at risk for IEP is limited. So we don't have a lot of information to say it's good, bad, or indifferent. Now here's optimized fluid resuscitation. So we want this patient on strict INO. We want to know, is their urine output gradually going down? And a dear friend of mine, many of you guys probably know her, Connie Barton. She's a past president of National ACN. When she used to lecture on hemodynamics, she says, you don't need a pulmonary artery catheter or a Swan-Ganz catheter to know if your patient's cardiac output is going down or not. All you need is the Foley catheter, or what she would call the Euro Swan. So really, you want to monitor strict INO, because that's going to let you know is your cardiac output dropping. And then you want to assess the patient's response to fluid resuscitation. And I know many of us are using the passive leg raise test to see if our patient is fluid responsive or not. However, there have been a couple of research studies that indicate that if the patient's intra-abdominal pressure is 12 or greater, that the passive leg raise test is not a valid indicator. So you want to assess patients' response to diuretics. So you give them, Lasix 40 milligrams. Are they peeing? And then the goal, and this is from the abdominal compartment study, is that you wanted to get to 0 or negative fluid balance by day 3. So again, you have your septic patient who you're pounding fluids in, but then you want to decrease that fluid amount and get it off if needed. So again, this is just, reinforcing that passive leg raise is not accurate when the intra-abdominal pressure is elevated. And these are 2 articles that support that. Now, as far as hemodynamics, so you want obviously goal-directed fluid resuscitation, but you want to request parameters for the fluids. So if the doc is ordering fluids, you want to say what to the MAP, to stroke volume, and so on. So again, request parameters, and I'll talk shortly about the hemodynamics, and then obviously titrate your fluids and vasopressors to meet those parameters. So this is another free download from the Abdominal Compartment Society, and I just pulled out this one section here. And they say maintain APP greater than 60 with vasopressors, optimize ventilation, and so on, and use transmural airway pressures. I know they use these in Europe. I'm not aware of them being used in the US, but this might be something we should start looking into. And what they also say is consider using volumetric preload indices. Indices like the wedge and the CVP are static. They're not volumetric. So examples of volumetric indices are stroke volume index, stroke volume, and pulse pressure variation. Now realize these last 2 are highly variable. The patient needs to be on a ventilator, on assist control. They can't be an atrial fib. So really your best bets are the stroke volume and stroke volume index. Whether you use it through a pulmonary artery catheter or whether you use it on one of the non-invasive cardiac output monitoring devices. And then as far as education goes, you don't want to forget the patient and family education. And I love this funny. How bad is it, doctor? Should I start dating? Okay, so that summarizes the most important parts of the nursing management guidelines that that I feel need to get out there. Realize that the full guidelines are in that article. The article also covers the nursing guidelines for the open abdomen. Okay, so one thing I want to point out to you, especially those of you who might be working on your master's degrees or doctoral degrees and you're looking for research projects, this is a very fertile ground for nursing research. We need further research needed on patient positioning. What is it that nurses do or don't do that affect the intra-abdominal pressure? What are the outcomes? There was a great study published in 2010 by Mike Cheatham and his research nurse about the outcomes of patients when you consistently implement the medical management guidelines. Well, what if you did both? What are the outcomes then? Can we improve them even more? And what is the effect on enteral nutrition on intra-abdominal pressure? So again, realize that there's a fertile ground for nursing research here for those of you who are looking for research projects. So now I'll pause and turn it back over to Brian to see if there's any questions.
All right, thank you very much, Rosie. So we've had a couple of questions come in. For those of you who are dialed into and listening to Rosie, you can enter your question into the chat at the bottom of your screen. That will go to me and Omar, and we will ask our presenter here the question. So we've had a couple of questions go in, and these are questions you've probably heard before, Rosie. You know, the first one is, how do we, the nurses, get the physicians more involved in intra-abdominal hypertension and managing it?
Okay, that is a good question. And I can remember my frustration. The first time the hospital that I worked in before I went into EICU was a rather small hospital. It was pretty much run by the hospitalist. We had one intensivist. So our intensivist and our surgeon was very much bought into this whole topic. However, when I brought it up to the hospitalists, their reply to me was, well, don't be calling us all the time with the pressure readings. And it was like, oh, brother. So luckily, this was only done in ICU. So what we did is we sat down with our medical director and you know, some of the nurses and our nurse management and so on. And we came up with a nurse-driven protocol on what patients we can go ahead and implement intra-abdominal pressure monitoring on without, you know, a given physician's order. And then also within that protocol, we had nursing interventions, pretty much like what I have gone through, to make sure the intra-abdominal pressure is managed and when do you call the physician and so on. So number one, I'd say, you know, meeting with your ICU group. Now, again, sometimes this topic is, you know, falls off of people's wayside because something else comes up like COVID or whatever. And so what I recommend is that you periodically re-educate both your staff, the physicians, and so on. So keep it out there in the front of, you know, so that everyone is aware of it. Make it something that when you do your interdisciplinary rounds that it's mentioned. I would do that all the time. If the patient met criteria for intra-abdominal hypertension, they had a urinary catheter in, we'd go ahead and implement it.
All right, great, Rosie. Well, I think I know which follow-up question I want based on your answer there. This one kind of goes hand in hand from one of the nurses who's dialed in today. Say, how do you initiate the competencies and maintain competencies with IEP monitoring protocols and guidelines in your institution?
Okay, so that is another good question. And again, during orientation, nurses would be, you know, getting the skills. I had several nurses who were IAP champions within the unit that would help me with the training and the education. So as far as setting up the device, using the device, managing the device, that would be like a skills checklist that either myself or the nurse champion would take the nurse through as they were setting it up, kind of like a see one, do one type situation. And then to maintain competency, you know, depending on, we follow what's called the Donna Wright method, so to speak, of maintaining competency. So if a nurse set up and maintained intra-abdominal pressure monitoring for a patient throughout that year, we would do evidence of daily work. One of the champions or myself would monitor them doing the setup, and we just, write down the patient's MR number, the date, time it was done, and write a note that yes, that they were competent in doing this. So actually looking at actual daily work. If that was not available, then again, using the checklist with kind of a mock-up so that they can set up the intra-abdominal pressure monitoring device. But also the important thing is that not only that they know how to set it up and take the readings, but what do they do with those readings? So again, if it was looking at their daily work, we would ask them, if they got a pressure of 12, well, what does that mean? And so we would discuss their findings so that we knew that they knew what to do about it. For those that didn't, I had a little quizlet that gave them various patient scenarios with different intra-abdominal pressure readings. And they had to put down what they could do to, affect those intra-abdominal hypertension readings.
All right. Thank you, Rosie. Next question is from Maribel. So Maribel says, first of all, Rosie, this was a great refresher. So they're asking, can you please discuss tube feeds in regards to deciding to or not to evaluate intraluminal contents? I check for residuals. What would you recommend?
Oh boy, residuals. All right. So if any of you guys, when it comes to residuals, that is one of those, what they call sacred cows of nursing. And actually what the evidence states is that you do not need to minimize or hold your enteral feed unless the gastric residual is 400 mLs or greater. So I know some nurses who hold it when it's 50 mLs, but realize even if you're doing like an enteric feed, not a gastric feed, your stomach usually always has about 100, 150 mLs of gastric juices in it. So again, when it comes to residuals, please look at your procedure manual or look at your protocol or practices, and realize there's a lot of literature out there that supports not stopping enteral feeds unless your gastric residual is 400 or greater. And then what they say is if it's greater than 400, stop your feeding for about an hour, recheck the residual. And again, there's other, I'm drawing a blank right now, but my friend, Joanna Barilla and myself developed this one tube feeding thing. And Jojo, if you're on this, if you can just type in, what was the name of our volume-based feeding, I think is what it was called. It's a certain protocol. Yes, volume-based feeding, that was the correct one. Thank you, Jojo. And again, this has to do with if you do need to stop it for any reason or slow it down, there's a way to catch up so that they do get their full nutrition amount. Thanks for asking that question. That's a good one.
All right, thank you. Now we've got another question here from an anonymous participant, and they ask, what percentage of patients in the ICU, surgical versus medical, would you want the ability to measure IEP on and have a protocol-driven guideline?
What percentage? Well, that would be hard to say. I'd say any patient that has risk factors. Now, again, when you see that list, it's just about every single patient in the ICU could probably benefit from it. What we did in our ICU is, as far as the nurse-driven portion, the medical director and I, we looked at the top diagnoses that we tended to get in that unit, like pancreatitis, ascites, sepsis, respiratory failure, and so on, fluids. And so if the patient had any of these, the nurse can independently go ahead and start measuring intra-abdominal pressures. So again, the reality is we probably don't do it enough. I know we don't do it enough. I'd say maybe 10, 15% of the patients get it, whereas really more needed, because 50 to 80% of ICU patients have some degree of intra-abdominal hypertension.
Okay. And I guess probably last question, Omar, how are we doing on time here?
We're good on time. We got about 10 minutes to go. So go through the questions.
Okay. Well, I have a question myself, and it's kind of also something that you taught me years ago, Rosie. You know, you said it in your deck when you started that the word you used with me is, I was very focused on surgery and trauma and burn, from a commercial device standpoint, from an engineering standpoint, because that's where all the literature has been published for the last 20 years. But you grabbed me and you said, it's much more insidious and it kills more people in the medical ICU. And you have this little phrase that you always say about, bombs going off in the gut. Can you expound on that and tell the group, because in your institution and working with you in the past, you had surgery, but you also had a lot of medical disasters that kind of rolled through your ICU over the years. Can you kind of expound on it? Because this is something that I've seen a lot traveling around the hospitals, to where there's a lot of awareness in the surgical realm, but it seems to be this very insidious clinical trend that happens in the medical ICUs, and then when it's bad, it gets really bad in a hurry. Can you expound on that?
Yes, and the thing that I used to say is that if you don't look after the gut, it's going to come back and bite you in the butt. Okay, and that goes, for a lot of different things going on in the gut. But you are correct, and again, it's reinforcement as far as the medical patients with intra-abdominal hypertension, keeping it out in front of your physicians, your medical director. And luckily, we had a medical director that was very tuned into this and very, advocating. So again, working with your team, keeping it out in front, and also impressing upon it to the nurses, because what I would hear from the nurses is that, well, we're measuring this every 4 hours, but nobody's doing anything about it. So again, impressing upon the nurses what it is that they can do, and then again, also keeping out in front of our teammates, the physicians and respiratory therapists and so on, about the importance of the medical patient and their risk of intra-abdominal hypertension.
So we've got a new question. Could you please, from Michaela, could you please touch on intra-abdominal hypertension and the correlation, it looks like, relationship with PEEP on the ventilator?
Oh, that's a good point. Yes. And that's listed as one of the risk factors. The higher the PEEP, the higher the risk of intra-abdominal hypertension. Because again, the pressure within the intrathoracic cage, also, remember, first off, 50% of what pressure that's in the belly will be reflected up into the thoracic cage. And then you add PEEP to that, and that can increase intrathoracic pressure, but it can also increase intra-abdominal hypertension. So again, if you can't get your readings down, you might want to reevaluate the PEEP and maybe use alternative ventilator settings. Okay.
And then, not to plug our own IP device that Potrero makes, APRN, but, this is a question that I get asked a lot, Rosie, is, when hospitals want to start measuring intra-abdominal pressure or institute an evidence-based practice guideline or protocol for their facility, where should they go for resources, about devices and so forth? There's a lot of resources that have been published in AACN and World Society. Can you just briefly talk about, if they want to get started from scratch, where do they go? What's the best ones?
Okay, so what I would recommend is going to the World Society's website, because they have a lot of free downloads and the literature that the evidence is based on, and then also the ACN procedure manual. The ACN procedure manual is evidence-based. We have to back up everything we write to validate before it goes in there. And I am in the process of revising the intra-abdominal pressure monitoring procedure as we speak, to go in the updated, I think it's the 7th or 8th edition of the AACN procedure manual. So I would say the website and the AACN procedure manual.
Fantastic.
Okay. Now, Rosie, in your capacity as the, oh, sorry, Omar.
No, you go. I insist.
No, So in your capacity, just being the nerd that I am, as an executive board member of the World Society of Abdominal Compartment Syndrome, you guys meet, every 2 years. You're in constant contact. You put out some great research. Where is the group going next? What's the frontier? What areas of, during COVID, post-COVID, the types of research your group is going to be focused on?
Well, I know that your device has brought a lot of excitement, especially to the group over in Belgium, because we never had a continuous reading before. I mean, there were some publications on continuous readings, but they were very cumbersome and not easy to set up. So I'm thinking, your device, it's like, well, what happens if we give the patient a back rub? Will that increase or decrease IAP? Actually, I did a small research study that showed that it brought it down. Does a sideline position, does a supine position, if you maintain that supine position, I could go on and on, but I won't, because I know we're short of time. But I think that we've done a lot of good research with the devices that we have available to us. There's the Foley manometer that's listed in the ACN procedure manual. There's the Crone technique that you can use with pressure tubing. But your device is kind of like a new thing that we can now start playing with to get even more information on the effects of intra-abdominal hypertension on our patients.
Got it. Thank you, Rosie. So Omar, I know that we're getting close to time, so I'll turn it back over to you.
Yeah, maybe we'll do a couple of quick questions. So I wanted to make sure we give this one. And again, thank you everyone for submitting all these questions. Unfortunately, we can't get to all of them, but we had an anonymous attendee ask, could there be a correlation between IAP and sacral pressure injuries in patients that are in the ICUs?
Ooh, hey, I like that.
That's a good one.
See, a fertile ground for nursing research.
I don't know why anonymous. You should let us know who you are. It's a great question, but go ahead.
Yes. If you need, that is a great question, and we need an answer to it. So let's do some research.
Last question for you, Rosie, kind of unrelated things, but I'm just kind of going through the attendees, and we had a lot of people show up. A lot of people who I see that are new nurses, those who are in nursing leadership. And for somebody with such a long experience in nursing leadership, one question I was going to ask is that what kind of resources or books, or anything that comes to mind that has really helped you really grow into a nurse leadership position that you can recommend?
Oh, nurse leadership. Okay. I would say I can't think of any one book offhand, but I would say the mentors that I've had in the past. People like Connie Barden. She was a great mentor for me. Ellen Reddick. She was a great mentor for me. So again, reading helps, but to actually put those skills into action, having a mentor advise you and observe you is what I found to be the best help.
Absolutely. And I think, the one thing that a lot of us forget, especially younger professionals, is that it's the best route for our careers. And it's as simple as maybe just sending an email or a message saying, hey, I really look up to you a lot. Can I take you out to lunch or maybe jump on a Zoom call just to get advice, right?
Exactly. Good idea.
So for all the nurses listening, just, reach out to those nursing leaders you look up to and just ask, because I can tell you that one of the great things about the medical community is that we're all always looking to teach and help each other. And more importantly, help those who are in the same shoes that we once were many years ago. So, well, wonderful. Rosie, we really appreciate you spending some time with us. I know that it's been very busy at the hospital, but it means a lot for you to take some time and share these wonderful insights and wisdom. And Brian, you're a great co-host as always. Thank you a lot.
Thanks for having me.
Of course.
Yeah, and what I'd like to say too is, whenever anyone asks me to talk about intra-abdominal hypertension, it's like asking me to talk about my grandchildren. I love speaking on this topic.
We love that. Well, I'm going to say, you said it here live and we have this recorded, so we'll probably ask you back again, because a lot of people have really gotten excited about this. So thank you all for registering and coming in. Again, just a reminder, you will be receiving the recorded version of this podcast in your emails in a few days. You can share that directly with your colleagues. And Rosie has been kind enough to share the slide deck, which of course has some extra slides in there for you. So Once again, thank you all for joining another great webinar with Petro Medical. Be safe. We wish you well, and we'll see you all soon. Bye, everyone.
Bye.
Thanks, guys.